I'm very honored to introduce to you Dr. Janet Pop. I'm sure most of us know her. She has been attending some of our meetings, webinars, and we listened to her in person in many other meetings in the good old days where people can get together. But hopefully this will be coming again. Dr. Janet Pop is a very famous rheumatologist. She is from University of Ontario, and it's very difficult to mention all of her credentials. She has been very active in inflammatory diseases, and she has done many publications, and we have been fortunate to listen to her before in person. So without more delay, I would like to introduce, it's an honor to introduce Dr. Janet Pop. Please.
And thank you very much. My heart goes out to the Lebanese people, not just with COVID, but the explosion. It's been quite a year for you. So let's hope that 2021 will bring great value to everyone. And thank you for inviting me, and thank you, Pfizer, who's sponsoring this. I want you to be able to vote. So your link, you should be able to have the polls come up. So this is my CV. So we're going to talk about treatment of RA with JAK inhibitors of the approved JAKs. So I'm not going to talk about newer data at this point in time that aren't yet published or drugs that aren't yet approved, because we know that we will have probably at least 4 JAK inhibitors approved in rheumatology over time, and that you, like us, have 2 approved currently, or 2 that you have access to. In addition, we will be talking as well about telemedicine or what's happening with COVID. So the treatment of JAK inhibitors in rheumatoid arthritis, we know JAK inhibitors that tofacitinib is approved in rheumatoid arthritis, 5 milligrams twice a day, baricitinib 2 or 4 milligrams a day for you, upadacitinib approval pending, already approved in some countries, filgotinib approval in some countries as well, and psoriatic arthritis as approval with tofacitinib 5 milligrams twice a day. So lots going on in this space. And these are my opinions, and obviously Pfizer and the Lebanese Society of Rheumatology, will not be responsible for my opinions. So I want to look at treatment strategies and insights for advanced therapies in RA. And we can start with the case and have some practical tips beyond then. These are my disclosures. So the first is a case. So this is a 41-year-old man, seronegative but erosive rheumatoid arthritis, almost 10 years of disease. And you can see he's had a right wrist fusion. You can see subluxations of the MCPs, flexion changes at the 5th PIPs. And you can actually see some swelling at the 2nd and 3rd MCPs, probably a little bit more active on the left than on the right. He has a fatty liver, not cirrhosis though. He's been non-compliant with no treatment the initial 3 years. And he's been flaring for 6 months shortly after his last appointment. And basically what we see here is that we basically see he has active disease. So his S-dye and his C-dye are elevated. Then you find out, so unfortunately this man has low health literacy. So you can find out here that he has stopped he was on triple therapy, methotrexate, sulfasalazine, and hydroxychloroquine, but he didn't understand that once you feel better to continue it. And this has been an ongoing problem for him. So he stopped when he was feeling that it was effective. Then he flared. So he restarted methotrexate at 15 milligrams once a week. He had been on 25 milligrams once a week. He's flaring now. So I want you to vote. So the polling will come up. So if your patient is not achieving your target on methotrexate 15 milligrams a week, good tolerability, fatty liver, but no cirrhosis, do you increase the dose, change to parenteral like sub-Q or intramuscular, do both, add another CS-DMARD, switch to another CS-DMARD, or add an advanced therapy? So damage, some disease activity, will have you vote. And we won't let the poll run for too long because I'll get a sense of the answers. and we will continue from there. So lots of options. You might say, oh, I do many things. I'll put them back on triple therapy. I might increase the methotrexate and give parenteral. So lots of options. So this is a study from early RA. This patient has 9 years of RA, but we have published this in past from our early arthritis cohort in RA in Canada, and found that retention was better on subcutaneous methotrexate than oral methotrexate, and that the change in DOS was deeper if you were on parenteral sub-Q methotrexate than oral. So that is something we sometimes will do in Canada. Even in COVID, we are putting people on injectable agents. Okay, so what happens is he does go back, say on triple therapy, his methotrexate's increased, maybe it switched to parenteral. He doesn't get back into remission, so he still has active disease. He's now switched, we'll say, to sulfasalazine and leflunomide because of intolerability and lack of efficacy. His CDI, though, is still 23, 5 swollen, 8 tender, MD Global 4 out of 10, Patient Global 6 out of 10, CRP elevated at 10, and normal is to 8. So a little elevation, and this patient is seronegative but has had damage. So what do you do after your conventional synthetic DMARD inadequate response? So there's lots of answers, but I'll have you choose. So you can choose TNF inhibitor, IL-6 inhibitor, abatacept, rituximab, which might not be yet available because he's not TNF inadequate responder, but in some countries you can use it after CS-DMARDs, or a JAK inhibitor. So again, we'll have you vote. And lots of right answers will come up, and we'll just show the polling answers here. So we know that basically EULAR says after failure of conventional synthetic DMARD, so inadequate responder to methotrexate or combinations, or methotrexate plus corticosteroids, you can add a bio-DMARD, TNF for the other classes I mentioned, or a JAK inhibitor, and then that you're still going to try to treat to a target. So again, a question for you. I'm hoping polling is coming up for you. Do you vaccinate for herpes zoster routinely in your RA patients? So your answers could be only if starting a JAK inhibitor, only if starting a JAK and age at least 50 years, not usually. I assume the family physician will do this when appropriate, or no. And sometimes it depends on access and coverage. We've been fortunate, I'm letting you vote now. We've been fortunate in Canada that we've had Shingrix approved, the non-live stronger vaccination approved for several years now. I realize that it's not available in every country and there's been shortages. I also realize that Zostavax, the live attenuated, is not as successful as Shingrix in preventing shingles and post-herpetic neuralgia. So moving on, the reason that we talk about this is not just when you're thinking about a JAK inhibitor, but the risk of herpes zoster will increase. So you can see the risk goes up in adults. The adults is the gray, and you can see it going up over time, but you can see the blue that really a 21 to 30-year-old RA patient has about the same kind of risk as a 51 to 60-year-old general population. And in general, Shingrix, when it is approved in countries, it's usually age 55 or older, or immune suppressed 50 or older. But again, that will vary in each country and it's not always available. But you can see the main risk really starts going up at 51, but especially 61 to 70 in our RA patients. And this was a lovely study. It was actually of 50,000 RA patients from a claims database. So these are very helpful data for us, but this would be US, and you have to look, is this generalizable to your patients or not? So the risk does go up over time. The other risks for herpes zoster reactivation in RA are active disease, chronic glucocorticoids, past herpes zoster infection of shingles, and obviously JAK inhibition increases the risk and probably doubles the risk of compared to another advanced therapy such as a TNF. Then we have published in Canada some recommendations, and I think the most important thing is just vaccinate your patients. But what we've said is it's best updated before starting immune suppressive therapy if you can in your patients, but you can administer non-live vaccines safely and optimally for live vaccines, which Zostrix is live, Shingrix is non-live, is 2 to 4 weeks before starting or restarting therapy. And depending on therapy discontinuation, depends on the background drugs. So our recommendations are just vaccinate. However, because you're vaccinating, it might be an expensive thing if it's not reimbursed for your patients. Ideally, you want them to mount a good response, and rarely they will flare their RA on a strong gamma interferon drug, vaccination like Zostrix. So you could hold the dose of a JAK inhibitor for 2 weeks after a vaccination. And for Zostrix and Shingrix, it's a vaccine dose and later a second dose. So 1 to 6 months later, the second dose. The other thing that's important is pneumococcal vaccination for our patients over the age of 50 who are immune suppressed, or maybe any patients, or maybe you're not going to do it till over age 65. This was a nice study at ULAR showing that if you look here, the vaccination has increased over time. So the second half of the graph is a newer era looking from December 2018 to January 2000. You can see here that there's been better vaccination by having a systematic vaccination in process. So 55% of patients, this is from the UK, have been vaccinated where appropriate for the pneumococcal vaccination. So again, you'll look at your country guidelines, but there was a nice study at ACR showing that actually vaccinating the patients decreased pneumococcal infection. And I think that's important to note that it does decrease infection. Okay, what about JAK inhibitors versus adalimumab and methotrexate inadequate responders? Because you might want to choose a TNF, a JAK, an IL-6, and abatacept, other drugs. So the oral standard, to remind you, these are data at 12 weeks or 3 months, looking at tofacitinib, the approved dose of 5 milligrams twice a day, was about the same as adalimumab. There was no head-to-head in this. It was tofa versus placebo and adalimumab versus placebo as a benchmark. And you can see here the rates of improvement. There is also, again, looking at the RA Beam trial where you can get improvement from 4 milligrams of baricitinib, and you can also look at the upadacitinib. Then if you look at a different way of looking at tofacitinib, 5 milligrams twice a day in methotrexate inadequate responders, this is looking at whether 3 ways of treating patients might be equal, and they are not equal. So because switching from methotrexate in inadequate responders to tofacitinib before you know it's working is not as good. You can see the ACR20, 50, and 70 are the lowest line here if you switch from methotrexate monotherapy to a tofacitinib monotherapy. But if you're looking at ACR20, 50, and 70, you can see adding tofacitinib 5 milligrams twice a day or adding adalimumab 40 milligrams every other week to the methotrexate are statistically not different. You can never call something the same, but they weren't non-inferior. They were about the same, but it was inferior to use tofacitinib as monotherapy in that case. So now, when you're thinking about a drug to choose for your patient with RA who has failed conventional synthetic DMARDs, does retention, the idea of how long a drug might work for, affect your choice of first advanced therapy in RA? Yes, always. I hope you'll be voting. Yes, sometimes, occasionally, or no. So the polling should be coming up and you should be voting on this. And lots of right answers here, no wrong answer. And in honesty, I have thought about retention now for probably the last 15 years, because unfortunately, none of our drugs works long-term in every patient. And there is a lot of cycling going on of our advanced therapies. And so sometimes even looking at retention between TNF inhibitors, I will try to choose one with longer retention or not choose one with shorter retention. TNFs all seem to work about the same in the short term, but the retention always seems attenuated, as for instance with infliximab compared to etanercept, in my opinion, looking at databases. Okay, so this is a study not published. It's been presented both at ACR meeting we just had, but also presented at EULAR. So this is called the Jackpot Study, and it's data from many European registries, also some Canadian data. So there's data from many sources in this registry, and it was 25,000 RA patients, of whom 6,000 were on a JAK inhibitor, almost 14,000 on a TNF inhibitor, 2,000 on abatacept, 3,000 on IL-6 inhibitors. And the question here was, if data are combined and you're adjusting by line of therapy, you're doing propensity matching for age, disease duration, but particularly for line of therapy, you can see that here, at least it looks that JAK inhibitor retention, the purple, is longer than the other ones. Now, this is usually the case, not always the case, but sometimes the TNF inhibitors have the worst retention. But here, the worst retention is all the other mechanisms of actions combined compared to JAK inhibitor. Is this always the case? It is often the case that JAK inhibitors have better retention than a TNF inhibitor. This is a nice study that is actually now published, looking at the Swiss registry by Fink et al., looking at tofacitinib mono or combo therapy. So just to talk you through it, it's not randomized, it's their registry, and looking at always the dot is monotherapy, the straight line is combination therapy. Black is tofacitinib, 5 milligrams twice a day. The blue is the non-TNF biologics, and the purple is the TNF combo, the straight line, the dotted line monotherapy. So it looks, in my opinion, that first of all, there's no retention that's going 100% over the next 2 years. There's a downward slope on all products, but you can see that statistically and numerically, tofacitinib retention is about the same on mono versus combo. And statistically and numerically, mono or combo are better than TNF retention, whether it's mono or combo of TNF. So this has been found as well in many studies, including one of the US billing databases or claims databases. So certainly here, retention looks better on the other products than the TNF, and it is numerically and statistically far better on combo or mono tofacitinib compared to TNF inhibitors, particularly TNF monotherapy. Then looking at Canadian data that we've published, we were lucky enough to get our first JAK in 2014, and it was tofacitinib. And you can see here, again, retention over 2 years. And this was on several hundred patients where we knew their line of therapy. And basically, you can see here, blue, the darker blue is in the middle for the overall retention. But if you were bio-naive, that's the orange, you had a little bit better retention than the other lines of therapy. We did not do stats on this, as this was just an observational study. And again, you can see that retention is not 100% over 2 years, that some people lose benefit over time on any product, including, in this case, tofacitinib, 5 milligrams twice a day. Now, when you're also choosing, you want to have safety, benefit, access, and obviously some degree, some of you want to have durability. So we can put the poll up. Do you think patients with active RA who need an advanced therapy prefer oral, injectable like sub-Q, intravenous, anything, just get them better? Or I don't ask, I don't know what they prefer, I don't ask, I just choose what I think is best for them. So again, we'll have you vote. and we'll see the various choices that come up. And you might have had the ability to pick more than one answer, because it sometimes depends on the patient. Some have a strong preference, some really don't. Many patients just obviously say to you, please help me, get me better, whatever I can get access to, and that you think could be beneficial and safe. Obviously, in COVID, you might answer this a little bit differently than prior to COVID, because it is more difficult to bring patients in for IV, but never impossible, or to teach them sub-Q, but again, never impossible. Okay, so this is a nice study that is published that just basically shows, so sorry, the publication has occurred. It shows that the oral is preferred. So this is asking RA patients, but the stage is set. If you have access and it has a pretty good chance of helping you and a pretty good safety profile, and you have access, what would you prefer? And patients say, I prefer a pill over injection and subcutaneous and over IV, strong non-preference for IV, strong preference for oral. And a lot of patients say they prefer no methotrexate if possible, but that's not always possible. And EULAR guidelines say, please continue methotrexate where possible. Okay, so now the next question is, in RA with JAK inhibitors versus TNF, do you think that there's a difference in patient-reported outcomes in function as measured by the health assessment questionnaire, in pain, usually visual analog scale, but pain, or fatigue, or pain and fatigue, or none of the above? So what do you think are the differences between the JAKs and the TNF inhibitors? And we will have you quickly vote. And there's lots of answers you might pick as being right. I think many of you know about pain seems to be better with our JAK inhibitors. So this is non-randomized, just a little study. So pain has been shown to be more effective on the head-to-head comparison trials. Not all are head-to-head, but on head-to-head comparison trials of looking at a JAK inhibitor at the approved dose compared to a TNF inhibitor, which, by the way, is the only head-to-head that we have data on so far of TNF inhibitors, or adalimumab 40 milligrams every other day. So we know pain can be more effective. So this is just a nice little study looking at fatigue from the German rabbit registry. And it looks like fatigue, although not statistically, but numerically better on JAK inhibitors, which is interesting. And better than looking at, say, as a, for instance, TNF inhibitor. But again, this is not a head-to-head comparison. It's just looking at the drugs in the rabbit registry. So pain could have been correct, or pain and fatigue might have been correct. Okay, if a patient is doing well on a JAK inhibitor plus methotrexate, really well, they're in sustained remission, say, do you taper treatment? So your questions to please poll and do your vote. Yes, I taper the methotrexate, such as EULAR guidelines. Yes, I taper the JAK inhibitor, which would be first in EULAR guidelines. Yes, if the patient wants to taper treatment, I'll taper. No, not usually. Why rock the boat? It's going well, or never. So you can vote and see what you think. And now we'll move on. So EULAR guidelines say, please consider tapering a JAK inhibitor if they're doing well or maintaining dose. There are no randomized controlled trials of tapering a JAK. So we don't have data there. Obviously, we have RCTs of tapering TNFs, and 1/3 to 2/3 can taper. But if you stop the TNF, you will have a flare in many patients. So don't stop it. The RA guidelines that were just presented say, don't taper, but if you're tapering, taper the drug that didn't work, which is a CS-DMARD. So the ACR guidelines are different than what the EULAR guidelines are. So this is a study looking at tofacitinib, long-acting 11 milligrams once a day. Now, first of all, I'm not going to show you the ACR responses, but the ACR responses for the first 24 weeks are quite high because everyone got product. They know they got product. So you could sort of think the placebo effect or the happiness factor is in there as well. This study, though, was based on if your patient gets to a very low disease state at 6 months or week 24, what happens if we randomize to stop methotrexate, which is the blue, or continue methotrexate, which is the orange, and that is the double-blind placebo part of the study that we're interested in. And this has been published and presented several times by Stan Cohen as the first author. And you can see here that from weeks 24 to 48, that you get no difference whether you continue background methotrexate when someone's in a very low disease state or whether you stop methotrexate. And so this was a non-inferiority. And so the assumption was met, meaning that there weren't statistical differences between the two groups. We all know sometimes when people lower or stop methotrexate that they will flare. However, the flare rates were not too different in the two groups. And we don't know what happens in the next 6, 12, 24, 48 months or years to come. What we do know is in the next 6 months, you can stop methotrexate, not even tapering, if you're on tofacitinib, if you're in a very low disease state. What about treatment after a TNF inhibitor? So some of you were certainly saying my first advanced therapy is a TNF inhibitor. I feel comfortable, I have access, there's biosimilars available, etc. So what do you use next? We'll put up the poll again. Do you do another TNF inhibitor, an IL-6 inhibitor, abatacept, rituximab? Now, any case in general, we'll just say it's seropositive. My case was seronegative, but we'll say seropositive patient with RA, or a JAK inhibitor, so one of the approved drugs. And there's lots of choices you can choose. They're all approved, the ones that are approved and you have access to, you're obviously going to consider. And so let's look at the data. So our poll here, so the data showing, again, EULAR says after an advanced therapy, you can either change the biodemard or go to a JAK inhibitor, but changing the biodemard could be a different class or the same class. And I'm on the EULAR guidelines, and I and others fought hard to say it's better to go out of class than to stay in the same class. But there's still data going in within the same class. So we thought it was a bit of a coup that the wording was nuanced and slightly changed, whereas it used to say within class or outside of class. Now it says a different class or the same class. So it's very nuanced. Why? Because there's data that going TNF to TNF don't have as high a response and don't have as long a response. And this is an example. So the ROC or ROC study from France showed that if you went TNF to TNF, you had less patients in a good response, of EULAR response, than if you went TNF to out of class. And in this case, the out of class, the doctors could choose whether they went tocilizumab. Half the time, if they're randomized out of class, they chose that. About 30% of the time they chose rituximab, and about 1 in 4 they chose abatacept. So they could choose whatever they wanted if they were randomized out of class. If it was TNF, they could pick the next favorite TNF. So going TNF to TNF. But you can see here always cycling TNF, which is the first of each column at 12, 24, and 48 weeks, is not as good as switching out of class. And that has changed my practice for a long time. This was published in JAMA 6 years or 4 years ago, presented way before that. So these are data again. So first, and tofacitinib, 5 milligrams twice a day, ACR20 is blunted, and the placebo is actually a little bit blunted. So that's oral step. And looking at DOS remission, 20% get a DOS of less than 2.6 and 5% on placebo. If we look here at the baricitinib 4 milligram data and 2 milligram data, you can see again, you get a blunted response here where you're getting the ACR20 and you're getting a DOS very similar, in my opinion, at 4 milligrams, a DOS less than 2.6 of 16%. For tofacitinib, it's 20%. So to me, the data look highly similar. And also upadacitinib, you will get a DOS less than 2.6 of about, again, anywhere from around 20 to 30%, depending on the study you're looking at post TNF. So Do you think the data on a JAK inhibitor in RA are different from TNF inhibitor? So you can select as many answers. Yes, better efficacy with a JAK. Yes, better efficacy with a TNF. No, same efficacy. Yes, better safety with a JAK. Yes, better safety with a TNF. No, similar safety. So as a, for instance, you could pick a 3 and a 6. So we are hoping that you're voting. And it's your opinion, so there is no right or wrong answer. So some people say, well, I think one might be more effective and the other's safer, or I think that there's similar safety, superior efficacy with one over the other. So lots of opinions. So I think as we move on, there have been concerns on safety of hypercoagulability or with tofacitinib, looking at the cardiovascular study, and I'm hoping we'll have questions on that. But my opinion on the cardiovascular study was that 10 milligrams twice a day gave more VTEs and gave actually higher mortality than either 5 milligrams tofacitinib twice a day in the high cardiovascular risk patients, and that is your approved dose, or then looking at a TNF, which was either adalimumab or etanercept. The study is a cardiovascular events study. It's still ongoing, so we'll get more data over time. Serious infection rate on 10 milligrams twice a day in the over 65 group was higher than the serious infections on the under 65 group, and it was highest with 10 milligrams twice a day of tofacitinib, which is why you have your warning letter. So that's what the data show. So I will stop there and give my conclusions that there are many options to use after a conventional synthetic DMARD, and you will make your own choices based on access, data, comfort, things like that, and based possibly on durability. It's difficult to predict which patient should get which product. JAK inhibitors are an effective treatment option post CSD-MARDs and also post TNF IR or inadequate responses. I believe cycling TNFs is not the most optimal treatment approach. But again, if you had many relatively inexpensive biosimilars, you might disagree with me saying, well, if I have cost efficiency, that might be best for my patient, or if patients prefer one thing over another. In general, though, there's a preference for an oral on a very large study compared to an injectable or an IV. And the long-term safety and durability of tofacitinib is known, and we're getting more safety and durability data over time. And with that, I thank you for your attention.
Thank you, Dr. Pop, for this excellent review and updating about JAK inhibitors. Thank you, Dr. Pop, for this great update about the use of JAK inhibitors. And we do realize in practice that they really have made a great difference. I have a question about, I think it's not from Lebanon, from outside Lebanon, about the contraindication for someone who has had a recent cardiac event. How about treating them with JAK inhibitors?
Right. So excellent question. So the first thing I'll say is that they've studied a large database in the US. After patients were hospitalized for an MI with RA, the chance of them going back on their biological drug was very low. It was only about 30% over the next year. So first of all, please treat your patients. Secondly, there are no contraindications to restarting any product or starting a new product once a patient's had a myocardial infarction. So there's no drug-drug interaction. So in my opinion, you can choose whatever drug you want to choose for them. The JAK inhibitors have shown to date no increased cardiovascular signal in the doses that are approved. So you could use a JAK inhibitor, you can use a TNF, you can use an IL-6, you can use abatacept, you can use rituximab if appropriate. So no problem.
Okay, we know that JAK inhibitors act quite fast. You know, they may act within a very short time compared to the others. How long would you wait on the JAK inhibitor to declare that it is not effective?
Right. So I think if you're thinking about a JAK inhibitor and trying to treat to a target, you would probably want to go 3 months. However, we know from every drug we use that if there's a really rapid downward slope of improvement, that patient will do better chance of remission, better chance of sustained remission. So that's just common sense that we've all learned, and every database shows that. So if your patient is on their 5th advanced therapy, you'll probably wait a lot longer than if they're on their 1st or 2nd advanced therapy. So at 3 months, if they have a good response but not at target, maybe you'll inject joints, maybe you'll optimize background CSD MARDs, or you'll just give more time. But primary non-responder is very rare. In any of our drugs, about 10% in my opinion on JAK inhibitors, and about 10% in my opinion on TNF inhibitors. So if at 3 months there is no difference and they are adherent, in COVID times, people aren't also filling their prescriptions. So you don't want to start changing products every 3 months if they aren't even taking it. But in general, at 3 months, if there's a very poor response or a adequate response, not great, and poor tolerability or transaminitis or cytopenias, you might move on. But at 3 months, if there's a moderate response, I'd give more time and adjust the other drugs like intra-articular steroids or a background CSD MARD. So 3 months, you should know a pretty good idea what to do on basically most of our products, including JAK inhibitors.
Okay, I think we have time for maybe one more question. Assume that you did allude to this, I think, in your talk, that if you give combination methotrexate plus a JAK inhibitor and the patient goes into remission, you said you could stop the methotrexate, okay, and continue with the JAK inhibitor. What if there are some financial constraints and you would rather, save cost effective? Can you lower the dose of JAK inhibitor and keep them on methotrexate for a longer time?
Right. Excellent question. So number one, we don't have data. Number two, patients are already doing it. Number three, patients who do it, if they flare, they'll go back up. So I think that would be absolutely EULAR guidelines appropriate. So am I doing it? Yes. Am I doing it very often? No, because we're fortunate that most people in Canada will have some kind of pharmacare. Not all, by the way, but we're fortunate that way. So financially, and that EULAR has said that, like, if you're on an advanced therapy, you can start backing off on the dose of the advanced therapy, but not stopping. So yes, you can do it. Do we have randomized trials to tell us to do it? No.
Okay. One last question, if you may allow me. In the era of COVID now, if someone is on a JAK inhibitor and feeling fine, responding well, and for some reason he becomes positive, PCR positive, yet has no symptoms, how would you approach this? Would you continue? Would you stop? And for how long?
Right. So first of all, why would the person get PCR if there's no symptoms? They've probably had an exposure.
Yeah.
So because there are people, 40% of COVID cases right now probably are asymptomatic or minimally symptomatic. So if they don't know they have it, they continue their drug anyway because they don't know and you don't know. However, if someone's PCR is positive, they can get symptoms in the next few days. So I would probably say hold your advanced therapy. Once you're feeling better, restart. Many people that are very minimally or asymptomatic, they could probably restart in under a week. So yes, I would hold if I knew they were positive for a week, then I'd restart. And that would apply for other drugs that we're dosing weekly, such as methotrexate, or if they were on a weekly TNF, hold your dose till you feel better or until you know symptoms haven't come. But CDC suggests that symptoms after your PCR is positive are usually, if they're going to be present, they're within the next 3 days. So 3 to 7 days would make sense to hold the drug.
Okay, thank you very much. I think we'll finish this part of your talk. The next talk will be moderated by our colleague, Dr. Kamil Mroui, who's the current president of the Rheumatology Society. He will be moderating the session that Dr. Pope will talk about the telemedicine in the COVID area. Dr. Kamil Mroui.
How are you? I'm Dr. Kamil Mroui. I'm here to co-moderate the session with Dr. Masri and Dr. Pope.
Hello, and I think this was excellent questions from the previous to go into the telemedicine part and COVID. So this is going to be a discussion. I just put up 2 slides for one of the first questions on whether you're doing telemedicine or not. So I can show that the reason we do need to see our patients is that they don't get sustained remission. And we all know that as clinicians. And so this is just data from our early arthritis, rheumatoid arthritis cohort of a few thousand patients from Canada, greater than 3,000. And of those who reached remission, only 55% had sustained SDI remission. So each year you see more yellow or red. That the first year of remission, we see about 55% of our patients get to an SDI remission, but only 55% of them are in sustained remission. So that's why we need telemedicine. So I guess one question we could all talk about is, what are you doing in Lebanon about telemedicine? Because I understand that reimbursement is a challenge.
May I talk? Actually, in Lebanon, telemedicine is something new, actually, though we may need it very much. The issue is with many aspects of telemedicine issue. One of them is technical issue regarding the availability of internet and facilities for the patients. Okay. Another issue is the financial issue. Okay. In Lebanon, we have a 100% liberal medical market. So we have most of our work is private based work. So probably we may have an issue in reimbursing our actually, if we want, our telemedical visit or interview with our patient. Okay. But I know these days that some of my colleagues, probably other specialties, are using wireless bank transfers to get reimbursed directly from the patients, or using companies that deal with money transfers these days, money exchange or something like that. They are using this, and it seems it's working for them. Third issue, I think, is the issue of time limitation. If you want to examine a patient online, is the patient very well knowledgeable of what's going on? Okay, is it time is consuming for us or not? Okay, in the end, I think face-to-face assessment of our patients at regular intervals is a must for us, at least in the first place, in the first visit, in our new patients.
Right. And I think in Canada, what I can say is there's different jurisdictions, so different provinces in the US, different state rules. So I would say right now, we are definitely in the second wave of COVID with many cases going up. So my colleagues and I were about 50-50. We bring in all new patients. We do what we can on the phone, then we bring people in to examine them or inject them, but that's very bothersome for the patient. It's like a double visit and means we need more time in our schedule. But Fortunately, we do get reimbursed, so it's very province specific, and we are trying to keep the elderly. So if we have an 82-year-old on low dose methotrexate, we don't bring them in unless if they're really flaring. So we're trying to be cognizant about that. Any other comments from your side of things for our panel before I show a little bit of data that patients can actually self-assess their joints if you teach them?
I have just one point I didn't talk about before. It's the legal issue of these virtual physical exam or meeting with the patient. Is it legal? You know, our work is all medical legal. What's the legality
Yeah.
of this
Right.
work
Right.
at this
Right.
point?
So rheumatologists never get sued in most countries because usually your patient likes you and things like that. We have been told by our malpractice, which is Canada-wide, our malpractice association, that these are untested times and that the standard of care should be the best possible, but they realize it will not be as optimal as if we weren't in a worldwide pandemic. So I think that it would have to be something very egregious, although I must say, 3 people since March that we've brought in, we picked up 3 different cancers. And if we didn't see them in person, we wouldn't have. So this was not expected. It was part of our physical exam, and 3 different lymph nodes that we found, all of which were cancer, a primary lymphoma and 2 metastatic disease that we never would have found without seeing them. So there is value, of course, to seeing patients. And in Canada, we're doing it over the phone. But medical legally, I don't think we're too concerned. We're more concerned about doing the best for the patient. So this here is just a nice study that, again, from our early arthritis cohort, as well as the US early arthritis cohort, looking at, can we believe the patients if you're phoning them or doing some blurry telemedicine through the internet, where they go like this and they show their hand going by, or they go, look, I'm swollen, and you can't really tell because they're not very good at it. The patients aren't used to showing their physical exam to us that way. But this is showing that if the patient says they're doing really well, the patient's CDI, which has no doctor involvement, where the patients have been shown to do their, like, talk a little bit, just told, please tell us what joints are tender and tick it off, and tell us what joints are swollen, that the physician CDI, like a normal CDI, and the patient CDI, which doesn't have the physician value. If it's a low CDI, you can believe them. They say, nope, nothing's wrong, and you can believe them. If it's a high CDI as well, you're going to bring them in if it's just over the phone, and there's a little bit more scatter at the high end than at the low end. But in the middle, you don't have a clue. The discordance is kind of great. So the agreement is about 0.7 of a kappa, which is actually pretty good. But in the middle where they go, I don't know if I'm flaring or not, you might have to bring them in. So that's what that shows. So I think the next question here to ask is this question here, if you can see it on the screen. So looking at what should we tell patients about COVID-19 and their medications? So if I can ask in the panel, what do you tell your patients? What do you tell them to do? What do you tell them about safety?
I have one question, just Dr. Pope, regarding the previous slide. You said we have the doctor's CDI and the patient's CDI. What about the normal values in these, let's say, in new scores? You know, in the patient's CDI, you have deleted the physician's global, and in the patient's on the patient's CDI, you deleted the physician's global assessment. What about the normal value? How can you tell this is normal, this is mildly active, or moderately or severe active?
Well, if you say the CDI is composed of tender and swollen joints in their global assessment, that is what you could get off of the patient's data when you phone them, right? They say, oh, I'm only swollen on my ring finger and the finger beside it on the right side, the joint that hooks to my hand. It takes forever to ask them if they haven't drawn a homunculus, but they can say, okay, across the base of my toes, which isn't part of your 28 joint count, and my wrist and my right, second, and third knuckles. And you go, okay, good enough. And are they tender too? No, just my feet. Okay, good enough. What would you call your scale of your RA disease activity from 0, not at all, to 10? Oh, I'd call it 4, they say. You can actually calculate. Now, we did this before COVID, because we were looking at agreement where when the patients filled out their forms in early arthritis clinic and the physician did their forms, but it was very almost like a premonition of COVID because it helps us. So that would be how it was calculated. But in general, most MD globals that are higher than what the patient rates, the patient rates higher than the physician. So if a patient says, I don't have any swollen joints, if we want to distill it down to that, and you looked on your chart before or your electronic medical record and you agreed with them before, you can agree with them. If they say they're highly active, you can probably agree with them and bring them in, but sometimes it's true, sometimes it's not. Sometimes it's they're erosive hand away. But in the middle, the certainty is less. There's a lot of scatter here in the middle, but that is very telling that these are not a real CDI. There are components of tender swollen by the patient and patient global, or tender swollen by the physician and physician global. So the normative values, you could just double what the patient global was, but we usually rank lower than they do because they live their disease and we don't. So patient global is often different. So I guess while you're thinking about this next question, what do we tell the patients during COVID? This was a nice presentation just done at the ACR saying that looking at multiple different countries that patients were masking, they were social distancing, but some of them weren't going out as much. And you can see here that this is really looking at 3,700 patients globally with rheumatic diseases or psoriasis. So they had to be online to even answer this questionnaire. But you can see that there's a lot of shielding, particularly in the rest of Europe. Canada had lots of shielding going on. We've been told to have masks 6 foot distance, which is, I guess, 2.5 meter distance, things like that. And then this is a study, and I like this study because they match. So this is a study out of Boston. And because our rules for COVID testing have changed like every month, almost every week, for a while, no one could get tested unless if they met where they had traveled out of country and fever, things like that. So the case definition changed, the travel got dropped. So this was age and sex matched, people matched for when a positive COVID test in Boston area with a rheumatic disease patient occurred, matching for another patient positive on the same day, age and sex match. So it's the best we can do, looking at rheumatoid arthritis patients. And so there's good news and bad news. The good news is the hospitalization was the same, going to the intensive care unit was the same, and also getting discharged and death rate was the same. So that's all the good news. The bad news was RA patients had more mechanical ventilation, but this was just like, that wasn't the primary outcome. It was really to see how they did. But if you got into the ICU at the same amount, and if you got out of the ICU or died at the same rate, I think we can say to our patients that they do about the same. And it's often the comorbidities that will be the problem. Having heart unstable angina or other known heart disease, having bad chronic obstructive lung disease, having severe diabetes. They are some of the risks. High dose prednisone is also a risk, although high dose prednisone, when you get to the ICU, is better to prevent having a cytokine storm. But steroids, like from the rabbit registry, corticosteroids, past infections are always a risk for patients to have more infections. But I think that that's very helpful. So what do you tell your patients? What do you say about their drugs? So I'll ask you in Lebanon for our panel, what do you tell them to continue or not to continue?
I think in general, we ask them to continue, but to keep, the recommendations to social distancing and using the mask and cleaning. And if they report any symptoms or if there is an exposure, I think they better contact directly their physician, rheumatologist, or primary care physician.
Yes. And do your patients stop drugs because they're afraid, even if you tell them to continue, or do they continue because you've asked them to? Do you get a sense of that?
Our patients are already informed before the COVID area that, they have to be careful about getting an infection. So to use social distancing, not to receive the injections when they are feeling ill or a flu or don't go out to visit people who know you know that you are ill. You know, we have a lot of socialization here, especially if someone is sick. People would like to go and pay a visit, so we always inform them to avoid these things. But you know, in reality, some of our patients have contracted COVID, mostly due to the other risk factors. You know, exposed to someone who was already carrier or sick, and them not knowing about that. So yes, we do tell them about risk factors, but we ask them to emphasize the instructions, you know, to mask and social distancing and cleanliness.
Exactly. That's what we do in Canada. And this is exactly on that topic, looking at the risks. Again, this is our early arthritis cohort. So as just coming in with RA, our mean age of RA is 54 in Canada. In France, it's about 51. I would guess in Lebanon, because you are a younger country than us and your median age, you're probably a bit lower. But looking here, we looked at the risk factors for COVID, and you can see older age. I mean, 60 is not that old, but advanced age. We have a lot of patients over the age of 60 with early RA. We have men have a worse outcome than women, but otherwise aren't a risk. But smoking status might be a bit of a risk, high BMI, hypertension, things like that. And we also looked at our vaccine status. So in Canada, it's recommended that everyone get their flu shot once a year. So 42% of our patients are doing that, not 100%. Getting pneumonia shot ever, 12%. Getting the zoster vaccine, only 6%, as it's not reimbursed in each province. It just got reimbursed in ages 65 to 70 in my province like 2 weeks ago. Steroids, though, are a risk of infection, and chronic obstructive lung disease is a risk for doing poorly with COVID. So you can see our patients should be in line to get vaccinated. And in general, George Shett and others showed a nice article they presented at ACR showing that patients on advanced therapies, at least anti-cytokine therapies, actually had less seropositivity and fared just as well. And in fact, they did slightly better. So certainly our patients should not do any worse. It's their comorbidities that might make them do worse. And as you all know, there's an awful lot of drugs suggested, usually not positive, but suggested in studies from baricitinib to IL-17 to the IL-6s. The IL-6s now have negative phase 3 trials, both of them for cytokine storm, to even colchicine, hydroxychloroquine, now negative. I think we can stop looking at hydroxychloroquine as helping COVID, but certainly doesn't hurt. So there are many pathways. Even a TNF inhibitor is in a registered trial to combat COVID. So you name it, there's a lot of our drugs might actually help. So I think that's kind of important. I'll open it up for any final remarks so that we don't go too much over time for our next esteemed speaker. But I think that this is good for us to think about the safety and the benefit. And as you get into higher and higher numbers, which I hope you don't, but the influenza in the early 1900s that spread across the world, I hate to tell you, had 4 waves. So hopefully this one will have only 2 waves, and then we're all going to hopefully be vaccinated.
Thank you, Dr. Pope. If I may have one question, probably related to the first part of your talk on telemedicine. Is there, or have you come about data regarding DAS score being used in telemedical interviews?
So I haven't seen anything published on that. And again, there would be, the DAS is just like looking at like a CDI or an SDI, right? A DAS has an inflammatory marker, so they have to go to a lab, either an ESR or CRP. But DAS otherwise has the components of pain, which is, well, patient global and pain are almost always identical, and tender and swollen joints. So it'd be the very same as the publication that, or the presentation that we did from our early arthritis clinic. It's just another formula using some of the components. But no, I haven't seen anyone present that way.
Thank you.
If I may have one last question, because time is becoming close. In all the patients who have become, positive, and they were on treatment, biologic treatment, rheumatoid or otherwise, is there any data? Are you aware of any data that would tell which group of medications were at more risk. And in particular, I have in mind, the interleukin-6. Have they been studied whether they really were more protected or less protected?
Right. So seralutamab stopped their phase 3 trial, and tocilizumab, in my understanding, about 3 or 4 weeks ago, also has preliminary results that their phase 3 study does not show protection of the cytokine storm. Like, they're treating the high-risk patients who are thought to actually have severe lung involvement. So they're trying to treat them before they're dying in the intensive care unit. And basically, both IL-6 inhibitors are negative studies. So my understanding, but I could be wrong, is that they've stopped looking. They weren't worse, by the way, they just weren't better. So it was a great idea to think about it, but it didn't work. And I think high-dose corticosteroids do work in the intensive care unit on cytokine storm in some people, and the recommendations are changing every 4 weeks or whatever. But certainly if someone's looking like they're getting severe lung involvement in a setting where they're on high oxygenation, they are currently given high dose intravenous corticosteroids with some positive studies.
Okay, but the question, people who were already taking treatment, did they really were more risk for getting the COVID, the ones who were taking interleukin-6?
So we don't know, probably not, but we don't know. So all we know, we can't do RCTs of our patients and then see if they get COVID or not. All we know is that our patients seem to do the same as other age and sex match patients if you adjust for coronary artery disease, chronic obstructive lung disease, advanced age, hypertension, diabetes, high BMI. They seem to do the same. So I think that's good to know. And certainly Global Alliance has some good data and has published on this, and the data are ongoing. So I agree. Chris is actually telling us this. Chris Edwards, thank you. And I agree. But they are these are biased samples, because sometimes when someone's died, we actually don't know. Many of us are part of the Global Alliance, and I've entered patients, and then I only know they have COVID after the fact. Usually I've known a few in real time. So if someone's died of COVID, I might not know until their follow-up appointment, because no one's called to tell me, right? So far, it looks like our patients are doing okay. You should possibly optimize their vitamin D, but that's my opinion. I think there's some data suggesting that low vitamin D patients do worse. So I have my patients in Canada, we have no sun anyway for a lot of months. So a lot of our patients are already on vitamin D, but I'm not doing levels in every patient.
For the lack of time, I need one short answer from you, Dr. Pope. If a patient is taking IV rituximab, and is he as higher risk to have COVID-19 complicated disease or not?
Right. So I will tell you two answers. Number one, the guidelines, particularly US, so the ACR guidelines have some caution around rituximab. Number two, do I use rituximab in COVID? Yes. Have I started many people on rituximab in COVID? Yes, because they've needed it. We're talking GPA vasculitis. We're talking severe RA needing treatment. And I tell the patients that they might not fight off infection as well. I think we have to go to first principles. We don't see, influenza virus comes every year to most of our countries, and we don't see our patients dropping dead higher rates than other patients with other equal comorbidities. And although COVID is a different virus, it is not influenza. We know that. We don't see severe coronavirus upper respiratory tract infections in past in our patients, because 1/3 of colds are coronavirus, obviously not this one. So I think if you go back to first principles, most of our patients' immune system is very intact. People who have lots of infections get lots of infections, and people who don't have lots of infections usually aren't going to die of COVID, but some of them will. And I think that's the best we can say. Use your own judgment, but I will not hesitate treating my patient appropriately and adequately despite COVID.
Thank you, Dr. Pope. Thank you, Dr. Masri, for sharing this session. Thank you.
Thank you very much.
Thank you very much. We have just 3 minutes break, and we'll come back. Don't go. Thank you.